All right, welcome back to you all. I hope you had a chance for a quick bite and a stretch as we launch the first of this afternoon's sessions. Now, this is our rapid fire session where we're going to have 8 presenters who have done research or are currently conducting research with Spectrum. Although these are pre-recorded for technical reasons, the presenters are actually available and will be listening in as well. So if you have questions or comments, please put them into the chat because they will be answered live. There won't be time for formal Q&A at the end of each of these presentations. We're just going to pretty much roll from one to the other. So if you have something to say or something that you'd like to ask, don't hesitate, just put it straight into the chat. You already should have received a link to a site that has all the presenter biographies, their abstracts and their presentation slides if you'd like to follow on. And I just wanted to remind you too that we do have an active Twitter feed happening right now. So if you are interested in tweeting, just go to hashtag Spectrum Research and join the fun. Alrighty, so before we run out of time, I better get started. So I just want to introduce our first presenter, the lovely Associate Professor Judy Hope, who I've been working with for a number of years. And she's a fabulous researcher, a very empathetic psychiatrist, and I really enjoy working with her. So Judy is the academic lead at the mental health program at Eastern Health. And in her own words, she is very passionate about working with fellow clinician researchers and lived experience researchers in her work revolving around Eastern Health's emergency department. Judy has over 50 articles published in the mental health field, and her presentation today is an aspect of our very large emergency department intervention program that we are working on with Eastern Health Emergency Department and Mental Health Services. So take it away, Judy.
Thank you for the opportunity to present today. I'm Judy Hope and I represent a group of clinical researchers from a tripartite project between Eastern Health Emergency Department, Eastern Health's Mental Health Program, and Spectrum Statewide Personality Disorder Services. And together we've been working on the issues around the experiences of people with borderline personality disorder in the emergency department. This paper is a report of an integrative review of consumer, carer and clinician experiences. Before I begin, I'd like to acknowledge the traditional owners of the land upon which we are meeting. For me, that's the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past, present and emerging. I'd also like to acknowledge any Aboriginal or Torres Strait Islander peoples here today, or any other First Nations people. I also recognise and value the knowledge and wisdom of people with a lived experience of mental ill health, their families, supporters, and the practitioners who work with them. We celebrate their strengths and resilience in facing the challenges associated with recovery. We know that the emergency departments are busy and overcrowded places and not designed to cater for people with mental health issues of any sort. We know that people with borderline personality disorder are overrepresented in emergency department numbers and may also present recurrently, and that there are unclear pathways out of the emergency department. The ED experience appears to be poor for consumers, carers and clinicians alike, and may result in poor quality care, escalation of mental distress, and potentially overuse of restrictive interventions. At Eastern Health, we are a large area mental health service that covers over 3,000 square kilometres of Melbourne's east and provides care to a catchment of over 900,000 people. And you can see us, we're the big dark pink blob to the right of the map. We have 3 emergency departments in our catchment who have recognised a need for change. Representatives from the emergency department have been meeting with mental health and statewide specialist services to improve care. Thus far, we have run a baseline staff survey looking at attitudes, knowledge and skills, We've run a short pilot project looking at improving our staff attitudes, knowledge and skills, and we're now bolstering our methodology by ensuring that we're across the available literature before heading into our definitive intervention project in February of next year. So we know that there's issues in the emergency department. We know that the emergency department experience can be very difficult for people with mental health issues. And there's been lots written about the experience of people who attend frequently or people who attend emergency departments with self-harming behaviours. We also know that people with borderline personality disorder may experience problems or issues in other sorts of care services. But there's been surprisingly little actually written about the experiences of people with borderline personality disorder in the emergency department specifically. So we set about to conduct an integrative review of what is known about the experiences of care for consumers, carers and clinicians during the care of people with BPD in the emergency department. In our search strategy, we compiled a comprehensive list of search terms and used search logic to interrogate 4 relevant journal databases: Embase, CINAHL, PsycInfo and Medline. We limited our articles to only be those in English up to June 2022. Articles needed to include borderline personality disorder as a major or sole focus, be ED specific and include some kind of outcome. Single case studies were excluded and the process of review was done through Covidence with a minimum of 2 reviewers. This was our specific and comprehensive search strategy. And when we ran our search across the 4 databases, 883 articles were returned. Duplicates and non-English articles were removed, and an extra 4 articles were snowballed back in, leaving 577 references. After titles and abstracts were searched, 13 only were left, and full text searches left 9 articles by the completion of that PRISMA process. Here is a table of the 9 articles that remained. Those with sharp eyes may count 10 articles, and that's because one of them, Spence et al., included both consumer and clinician perspectives in their article. The majority of articles focused on qualitative consumer perspectives, and the only article focusing on carer perspective was that of ACRES in 2021. Turning to our key findings. Consumers reported the emergency department as a place of last resort, which was undesirable but inevitable. People reported both good and poor care in the emergency department. Common themes included long wait times and very busy environments, which could leave consumers feeling deprioritised and dismissed. Consumers reported significant experiences of stigma and negative attitudes, resulting in feeling misunderstood, mistreated, judged, disrespected, disliked, and feeling inconvenient and undeserving. For those who returned sequentially, the familiarity could be both reassuring and negative when staff expressed exasperation. Discharged was reported as too early and too sudden, often in the night, or to inadequate supports. Carers articulated a mismatch in the expectations of the emergency department staff compared to community mental health or other community carers or services who endorsed the use of the emergency department. Carers often reported being overlooked by staff or actively excluded by both poor communication and excessive use of privacy legislation. Carers were often distressed by the poor treatment of their loved ones, including rejected needs and lack of privacy, and themselves experienced stigma and negative attitudes from staff. ED clinicians reported a high tension with the competing demands of the busy emergency department and endorsed their preference to provide physical health care. They endorsed feelings of frustration with people who presented repeatedly and did express stigmatised attitudes. Clinicians endorsed a lack of skills to respond to mental health crises and reported feelings of helplessness and incompetence when trying to assist people with BPD. Some themes were common across the groups. All groups endorsed the ED as busy, unprepared and unskilled for assisting people with BPD who are experiencing mental distress. Both clinicians and consumers endorsed a perception that people with BPD were seen as lacking legitimacy for attendance. And all groups reported that ED staff prioritised physical health needs over mental health issues. All groups endorsed a desire for change, and all groups saw that interactions could be better with improved staff skills, attitude, and communication skills specifically. All groups endorsed a need for better physical environment and a slowed pace for people with BPD, and all groups considered that systems change is needed, for example, in things like peer worker care and out-of-hours alternatives. At the completion of our review, there were some standout implications for our own staff education project. The first was that the shared goals of consumers, carers and clinicians for things to be better rested on our clinicians' understanding of the experiences of consumers and carers who attend our departments. This meant that the lived experience voice needed to be front and centre of our interventions. The second was that the knowledge of BPD was less important than a focus on stigma, attitudes and communication habits, so in turn our education package has strongly focused on these. In conclusion, I'd like to thank my co-researchers, Jo Miller, Elle Nguyen, Amanda Lamb, Peter Brand, Paul Bunteen and Gillian Broadbear. I'd also like to thank the amazing teams at Eastern Health and Spectrum who've been working so hard on this project over the last 18 months to create a better system for everyone. Thank you very much.
Thanks so much, Judy. That was fabulous. And it's really very, very helpful to have insights from consumers, carers and clinicians into the mental health and ED experience within our emergency departments here at Eastern Health. I want to move on now to our second speaker. This is Mr. Julian Nolan. Julian is working in private practice right now in individual and family therapy. He was a Master's of Clinical Psychology student with Spectrum and graduated quite recently. His project was in the sexual diversity intersection with borderline personality disorder, which is quite an understudied area and understandably adds quite a lot of complexity to presentation and some of the challenges around managing the symptoms of personality disorder. He has already successfully published one of his thesis papers, and I'm really looking forward to his presentation today on sexual diversity in people who have borderline personality disorder. Thanks, Julian.
Hello and welcome everyone. My name is Julian. I'm a clinical psychologist and I'm here today to present to you on the topic of sexuality and sexual diversity in people with BPD. The research that I'm presenting is original research that was conducted 2017 to 2019 as a part of my master's thesis component. During this presentation, what I want you to keep in mind is this quote on the screen. They are connected, but they're separate as well. I think it beautifully encapsulates what I'm here to present to you today about and comes from one of the participants in the second study that I'll be talking about in a few moments. But firstly, sexual diversity and why we're using this term. Sexuality and sexual diversity is defined as all the diversities of sex characteristics, orientations, and behaviors without the need to specify each of the identities, behaviors, or characteristics that form this plurality. Basically, we're using this as a catch-all phrase to avoid clunky terms such as LGBTQI, because there are some individuals that may not identify this, but may have an identity, an attraction, a behavior that is not within the realm of heterosexuality. So why sexuality and sexual diversity in BPD? Well, first of all, the literature shows us this is a topic that's often neglected, which for those of us that work with people with BPD, this diagnosis, know that it's something that would come up quite a fair bit given the challenges and difficulties around relationships and emotions. We also know from the literature that for some reason there is a much higher incidence of people identifying as sexually diverse or being identified, as these two can be quite different, in people with BPD. some of the literature as well in the past has attempted to link some symptoms of BPD to this, potentially not for the best reasons or not with the best outcomes, including perpetuating stigma, and that's why we want to investigate this. The fact that individuals with BPD are more likely to be sexually diverse could indicate poorer global mental health outcomes because they fit within two minority groups, people with a major mental illness and people in a sexual minority. Therefore being doubly stigmatized, not fitting into either category or not being understood at health services or in social circles. It also means that mental health clinicians might not understand their clients and their experiences and may have a harder time working with them, relating to them, understanding them, and eventually treating them and supporting them in their recovery. So the first study that we conducted is a large online study survey that has just been published, which is fantastic because it has taken us a number of years to get there. As you might appreciate, it's a very tricky and challenging topic to do research in when you're working with two groups that are often marginalized, and there are a lot of opinions around languages and particularities and a lot of sensitivities basically in conducting research in this area. But we got it over the line and it's published, and if you wrote down my email at the start, feel free to contact me and I'm happy to send you a copy of the paper because it obviously goes into a lot more depth of what I'm presenting to you here today. But basically the first study that I'm talking to you about, we were looking at between group differences between sexually diverse and non-sexually diverse people diagnosed with BPD. So we got them to fill out a whole bunch of information about their demographics, treatment experience, relationships, sexuality, sort of doing a Kinsey scale on who they're attracted to, who they've been in relationships with, as well as information about their BPD symptoms, identity disturbance, and impulsivity as well. So what do we find? First of all, we found that how you categorize people's sexuality or their diversity, how you label them as being gay or straight or whatever other labels you want to use, really changes depending on how you define sexuality and sexual diversity. This was something that past research had not done very well. So often clinicians had said, you know, this person has had sex with someone of the same sex, so therefore they're gay or lesbian. So what we did was we asked them, you know, from attraction, how they identify and their relationship history. And we found that depending on how you assessed this, you got very different results. We found that people with BPD that were sexually diverse were significantly younger and more likely to have changed their sexuality in the last year. But there was no difference in how long they'd been diagnosed with BPD for, how long they'd been in treatment for, how long, whether they were in a relationship or not, their level of BPD symptomology, whether they were more likely to have issues with identity disturbance or impulsivity or not. There are absolutely no differences. So what does this mean? Firstly, if you didn't gather already, that is very important to assess your client's sexuality in a number of different ways. It's not only asking them how they identify, but also asking them about relationships, sexual behavior as well, even though we didn't include this in the study, and also who they're attracted to. There were a number of people in this study that reported same-sex attraction but had never acted on it. And just maybe normalizing this is a very normal thing for people, particularly people with BPD. We also think that age gaps might reflect shifts towards acceptance in terms of older cohorts and younger cohorts. That what we know about change in orientation is consistent in the literature, that sexually diverse participants, it was only them who changed their identity. There was no one going from a sexually diverse, so being gay or lesbian or queer identity, to a heterosexual identity. And this is consistent as well with what we know about development of sexuality through our late 20s. Taken together, we kind of refute the linking of BPD symptoms to impacting or causing sexuality, sexual diversity, and that it supports some more recent research that came out since we conducted this in 2020, 2021, by Rodrigo Sayers and their colleagues. And there are a couple of really good papers if you're interested in this, suggesting that the high portion of people with BPD who are also sexually diverse is actually because of a bias in the symptoms commonly overlapping. So young queer people very commonly experience suicidality or self-harming behaviors, impulsivity, mood swings, difficulties with relationships, uncertainty about their identity, for example, and that this maps onto BPD symptoms, but is due to difficulties with their sexuality and not due to having undiagnosed BPD. Now there's a lot of information to take in. Hopefully the next study is a little bit more straightforward, where I interviewed 4 women, all living with BPD and all identifying as sexually diverse. We analysed this using an IPA format, which is basically getting us to understand what people experience and how they interpret the world. We wanted to know their lived experience. Then transcribed and coded the interviews. And what I'm presenting to you are the core themes that came out, that all participants spoke to a process of realizing and living their sexuality, the challenges that they face with living with BPD, then talking to the relationship between these two parts of themselves, the stigma, particularly the double stigma for being both a queer person with a major mental illness, and also societal expectations, roles, and programming and the impact that that had on them. So what did we get from this study? First of all, this is the first study of its kind of what we know of, interviewing queer people with BPD, and that basically their lived experiences do map to what we know firstly about people's overall lived experience of BPD, and also people's experience of developing and understanding and accepting their sexuality and their sexual identity. Where it divulges, I guess, from past research, or what it adds, is that the interaction between BPD and sexuality could be impacted by the increased emotional sensitivity that people with a diagnosis of BPD are likely to face and likely to experience. What it also has shown us, or suggests, is that BPD may be more of a developmental delay in that normative process of understanding and living and coming to terms with our sexuality through our teens and 20s. And so for these people with BPD, because of their mental illness and the difficulty with identity and emotionality and relationships, that it took them longer to settle on a stable sexuality, sexual identity, and sense of self. What does this mean for us? It's really important to adopt transparent, accepting, and non-judgmental attitudes working with people with BPD who may or may not be sexually diverse. That us as clinicians should be educated, learn from, and acknowledge our mistakes and mislabeling or not fully understanding their lived experience and their identities, and that it's okay to not know and to ask our clients. In future, there's a number of ways that we can improve this space, but it'd be great to do much more studies, including with other psychiatric and non-psychiatric populations, explore these variables and look at the unique experiences of stigma in these people to really help us work better with them to support them on their journeys. Thank you.
That was amazing. Thank you so much, Julian. And please remember, keep your questions and comments going in the live chat. Because our presenters, even though their presentations are recorded, they are available live to answer your questions and respond to your comments. So it's my great pleasure to welcome Dr. Rachel Joe as our next speaker. Rachel is a newly minted consultant psychiatrist, and she's currently working at Chandler House Adult Community Mental Health Clinic. She did a 12-month placement with Spectrum as her senior registrar rotation, and completed a scholarly project with Spectrum, which is the title of today's talk. I'm very excited to say that Rachel's paper has just appeared online. It's an open access article as preprint in Personality and Mental Health. So if you're curious to learn more, please check it out. So her title today is Late Manifestation of Borderline Personality Disorder, Characterization of an Under-Recognized Phenomenon. Take it away, Rachel.
Hi everyone, my name is Rachel. I'm a consultant psychiatrist currently working at Chandler House, which is a community mental health clinic for adults up in Upper Ferntree Gully. So I'll be presenting on my research project, Late Manifestation of Borderline Personality Disorder, Characterization of an Under-Recognized Phenomenon, which I completed as part of my scholarly project. So BPD and age of onset. We know that clinical signs of BPD usually emerge during adolescence and early adulthood, and that these symptoms are exhibited in an enduring and stable patterns. And we know that some signs and symptoms may remit in older age. Less commonly, however, it's been noted that clinical signs of BPD can emerge for the first time in middle and older ages. Anecdotally and from a few case studies, we see that these people have a reasonable level of functioning and psychosocial stability. And a life crisis occurs that precipitates a clinical manifestation of BPD, often quite sudden and quite severe. And there's often comorbid mood disorders or substance misuse. So the questions I asked for my Scholarly project was, can clinical manifestation of BPD occur for the first time later in life? And if so, what are the characteristics of this cohort that are similar or different from the general BPD population? So the study was conducted as a retrospective clinical file review, and these were of former and current clients of Spectrum in the last 10 years. I used a convenient sampling with prospective participants identified either by file reviews or in consultation with other staff at Spectrum. So the inclusion criteria was that they had to have a first formal diagnosis of BPD at or above the age of 30. They were excluded, however, if they had a formal diagnosis of BPD prior to age 30, or if they had a psychiatric symptom profile that would have fulfilled a DSM-5 criteria of BPD prior to age 30. They were also excluded if they had any contact with mental health services prior to age 30. And that was to rule out any potential misdiagnosis of people who have had earlier BPD presentations. So 23 cases were identified, and various clinical and psychosocial factors were reviewed for this cohort, including gender, cultural background, childhood trauma, family history, education and employment history, marriage, de facto relationships, other protected relationships, psychiatric history, medical history, substance use history, age at first BPD presentation, precipitating factors for the first BPD presentation, history of non-suicidal self-injury and suicide attempts, and presence of PTSD symptoms at first presentation. So there were 5 key findings in this research. The first was that there were people who presented with BPD for the first time in later life. And in the cohort that I studied, the age ranged between 31 and 63, with an average age of 44.9 and a median of 45. The second main finding was that in this late manifestation cohort, they experienced similar rates of trauma and other vulnerabilities. As you can see, there's high rates of childhood trauma, in particular emotional and sexual trauma. 2/3 of this cohort had a previous mental health diagnosis or substance misuse, and more than half of the people had a family history of mental illness. The third finding was that in this cohort, they had higher rates of education, employment, and long-term intimate relationships. It's unclear whether these factors were protective against earlier manifestation of BPD, or whether they were simply a reflection of a normal psychosocial development for people who would not have had an earlier BPD manifestation. But certainly we know from research that employment and interpersonal relationships are key factors in BPD recovery. And it seems like in this cohort that these factors were containing and protective for them. The fourth finding was looking at the key psychosocial precipitating factors in first BPD presentation. And there were 3 key things three key factors. The first was interpersonal problems, which is not surprising given what we know about borderline personality disorder and the difficulties they have with attachment and with relationships. It was interesting, however, that in this cohort, that this relationship difficulty was particularly with children. So these would include examples would be when the child moves out of home, or if the person was having difficulties parenting with the children's behaviours. The key precipitating factor was the loss of employment, which we know is a big protective factor and a containing factor for people. The third key precipitating factor was reminders of past sexual trauma. So these would include things like talking about their sexual trauma for the first time, meeting their perpetrator, or their child, or a person they knew who was recently sexually assaulted. So the fifth finding and the final finding was that the late manifestation cohort had high rates of comorbid mood disorder and substance misuse. At initial presentation, 80% had comorbid psychiatric diagnosis or was misusing substances. Because it was a retrospective study, it's unclear what's caused what, whether it is the comorbid disorder, often a mood disorder, that played a role in precipitating a BPD presentation, or whether these mood symptoms and substance misuse are a manifestation of a more primary personality disorder. We know that both do occur. We know that from research that people with major mood disorders, with relapses, their underlying personality traits may be exacerbated, and once their mood disorder is treated, their personality traits dissipate. Similarly, we know that mood symptoms and substance misuse is very common in people with personality disorder. So in conclusion, we know that there is a cohort of people who present with BPD for the first time in later life. And this cohort seem to have similar risk factors and vulnerabilities to the broader BPD population. However, this cohort is distinguished by its higher levels of education, employment, and long-term intimate relationships. And that interpersonal problem, loss of employment, and reminders of past sexual trauma were key precipitating factors in first BPD presentation. So I wanted to give special thanks and acknowledgements to my supervisors, Sathya and Julian, and also Judy for supporting me through this process. I also wanted to thank Numega and Peter for their initial works in collecting data for this project. Thank you.
It's really fabulous work, Rachel, and I'm so glad that this is now published for the benefit of all older adults whose personality disorder may well be overlooked. So moving on to our next speaker is Miss Chloe Dean, and Chloe is a bona fide student. She's doing her Masters of Clinical Psychology with Deakin University, and she's very lovely and she's been great to work with. We had a big interruption with COVID, but she's back on track. And very, very happy to welcome her today. Her research interests involve working with people with personality disorders, particularly in the context of gender norms and the impact of stigma on identity. And this is a very appropriate project for her as she's investigated the experiences of men who have borderline personality disorder. Thanks, Chloe.
Today I'll be talking to the research entitled A Qualitative Exploration of Help-Seeking and Diagnostic Experiences Among Men with Borderline Personality Disorder, BPD. So, why study this area? Well, historically, borderline personality disorder has been largely attributed to women, despite population studies indicating that half of those meeting criteria for a diagnosis of borderline personality disorder are men. As such, there's very little existing research on male-specific experiences of receiving diagnosis of borderline personality disorder. In consideration of this, the research also shows that the way in which an individual receives their diagnosis will likely impact their future help seeking and engagement with treatment. Indeed, what research there is on the diagnostic experience for individuals with borderline personality disorder is heavily skewed to women. But what is shown is that a positive diagnostic experience facilitates individual motivation, hope, insight, a sense of control, and engagement in treatment, ultimately mitigating risk. Conversely, it also shows that a negative diagnostic experience can foster feelings of frustration, anger, hopelessness, a distrust of healthcare professionals and services, ultimately creating more barriers to engaging in treatment. Understanding these factors necessitated the need to have a more comprehensive understanding of the ways in which men with borderline personality disorder make meaning of their diagnostic and help-seeking experiences. So, how was this done? Well, 4 men with a diagnosis of borderline personality disorder were interviewed utilizing a semi-structured interview guide that lasted for an average duration of an hour. These interviews were then transcribed and analysed utilizing interpretative phenomenological analysis. This is a methodology grounded in theory, where analysis focuses on describing, understanding, and interpreting human subjective experiences and meaning-making, making it appropriate for the current study. Especially with the small sample size, this enabled a deep dive into the individual men's experiences. Moreover, this methodology emphasizes reflexivity of the author, i.e., constantly reflecting on whatever experiences, biases one might have that might be influencing the way in which the data is analyzed. The data is first analyzed ideographically, meaning that each individual transcript is gone over independently many times. Then a thematic approach is taken, whereby the transcripts are looked across to see if any participants share unique experiences or perspectives. It's important to note that IPA does not attempt to identify one objective truth, rather tries to understand the individual's unique experience and how they made meaning of this. So what did we find from this? Well, from this data, 3 synthesized themes were identified, which helped to illuminate the experiences of help seeking and diagnosis among men. The first of these can be encapsulated as facing barriers. There's just no help out there. This theme demonstrates participants' experiences of constantly facing barriers and their determination in advocating and fighting to overcome these. First barrier, lack of information, can be encapsulated by the quote, "They never gave me information or anything regarding what I could do." This lack of information endured across participants' journeys and led many of the men to advocate for themselves for better care and for more information. Second barrier we see is the lack of appropriate timely support. This refers to the men's difficulty in engaging appropriate support from mental health professionals and services, again across all stages, and can be seen in the quote, "There was no mental health plan written up. They literally just released me and that was it." Indeed, across participants, it took an average of 18 years from first help seeking to receiving a formal borderline personality disorder diagnosis. Many cited frustration at this late identification, as they felt it meant that their traits were more embedded and it inhibited their ability to seek specific, appropriate, effective treatment. This late identification, in conjunction with factors such as staff attrition, short-term nature of services, ineligibility, being released from services, financial constraints, and wait times, all created further hurdles to progress for the men and to engage support. The final barrier is stigma, and can be seen in the quote, "The stigma surrounding people with borderline personality disorder makes it feel like I need to keep the diagnosis a bit close to my chest. I have an additional burden to carry." Indeed, this stigma was internalized by many of the men, in turn perpetuating their avoidance and denial of their mental health difficulties, creating a further barrier to them engaging and seeking support and seeing progress. The second theme can be conceptualized as self-understanding and identity. It refers to the need to understand oneself and seek out another hint in the crossword puzzle that is the men's identities and life. Indeed, this need to understand oneself was a key motivating factor for many of the participants. Within this, a key theme that emerged was the feeling of being an outsider across all participants. This appeared to be further augmented through aversive childhood experiences and can be seen in the quote, "I never grew up knowing who I was or who I could have been. I created this mask to hide myself." Indeed, several of the other men cited also masking their feelings in public, but also discussed how this masking subsequently exacerbated their unstable sense of self and indeed their emotional dysregulation when they're at home due to the concerted effort it took to mask in public. Moreover, in terms of this need to understand oneself, this indeed sparked varying levels of positivity upon receiving the diagnosis, as seen by the quote, "There is a reason and an explanation of why I've struggled so long that explains a lot of my behaviour and my history as well." Considering that feeling different and wrong sparked 3 of the men to seek mental health support, it is understandable that upon receiving this diagnosis, several of the men felt increased self-understanding and felt a positive response towards that. Finally, theme 3 refers to the importance of connection. I missed out on feeling loved and connected. Indeed, it demonstrates the profound impact of connection with loved ones and professionals. It refers to the positive impacts when participants experienced shared understanding, feeling a part of something larger than themselves, and receiving support and acceptance from others. Conversely, it also explored the ramifications where this sense of connection was not felt. Regarding connection with clinicians, where participants felt a strong sense of connection with their clinician, they cited greater treatment engagement, a more positive reaction to their diagnoses, and indeed more feeling of recovery. And that can be seen in the quote, "With my new psychiatrist, you can see the empathy, and you can see them basically wondering how you are and how you're feeling and how you're going. And that's a lot more reassuring." Again, this is in line with the literature emphasizing the need for therapeutic rapport when working with individuals with borderline personality disorder. Moreover, when considering connection, we also looked at this in regards to the participants' loved ones. This connection with loved ones helped one of the participants to confront his avoidance and recognize his mental health difficulties. And is encapsulated in the quote, "She knew there was something wrong. She communicated to me really well to help me see that, yes, there's something wrong. I'm not being a normal person." Showing that the sense of connection this man felt to his wife helped him to better hear and understand what she was trying to communicate. Indeed, connection with loved ones was seen to be beneficial across multiple stages, in supporting participants to stabilize in times of crisis, in supporting them to advocate when they were unable to self-advocate. However, conversely, it was shown that a key barrier to developing and maintaining connection with loved ones was the functional impairment associated with BPD itself. Indeed, there were instances of friends and carers citing needing distance from the participants or to end relationships as the carer themselves felt their mental well-being was being negatively impacted through the care they were providing. These were the key results that came through studying and giving a qualitative exploration of help seeking and diagnosis among men with borderline personality disorder. Indeed, this helps to illuminate a population that previously has been under-researched and under-recognised. Thank you for coming to the presentation today, and I hope you enjoy the rest of the day.
Great work, Chloe, and amazing getting your thesis all finished up, and I can't wait to help with the publication of your work. I'd like to welcome our next speaker, is Dr. Ian Ng, and Ian, we know very well at Spectrum. He completed a 2-year rotation with us in his senior psychiatry traineeship. And he's now a consultant psychiatrist working in public community adult mental health at Eastern Health. And he is very, very well versed now in how people receive their diagnosis of BPD. This is actually a really critical moment in any person's mental health journey. It's the way in which the diagnosis is communicated and contextualised, and all the psychoeducation and positivity around that has a huge impact on whether people accept the diagnosis and whether they go on to seek and successfully complete treatment. So very important work, and I'm delighted to present Ian with his talk, learning more about the consumer experience of receiving a diagnosis of BPD, a mixed methods study. Thanks, Ian.
Good afternoon, everybody. My name is Ian. Thank you for inviting me to this event, and apologies I can't be there live with you. A consultant psychiatrist working through Eastern Health, and commenced this study whilst I was completing my advanced training at Spectrum. As the title suggests, I was quite interested in better understanding the consumer experience of receiving a borderline personality disorder diagnosis. Quick acknowledgements need to go out to Gillian, Judy, and Sathya, who really helped support and guided me through the process of research, and also to Rita and Jacinta, who provided important feedback on the survey, which formed the crux of the research to ensure that it was consumer friendly and would help us get the best data that accurately reflected the true consumer experience. Now, it's no secret that there are a range of factors that really affect consumers in terms of being able to receive a diagnosis of borderline personality disorder and subsequently access appropriate treatment for it. Clinicians have a significant role in this, and certainly, as noted in the factors that I've listed there, their understanding or misunderstanding of the prognosis of the disorder, their reticence to or hesitation to provide this diagnosis based on their own experiences or fears or attitudes towards BPD seem to get in the way of potentially ensuring that people get it and receive a timely diagnosis. And at the end of the day, this has an important impact in terms of really restricting consumer autonomy in regards to them being able to accurately be informed about their mental health and then follow up with appropriate treatment for that. As noted, there tends to be kind of continuing stigmatized attitudes when people are help seeking with BPD, and that often, unfortunately, people with BPD still tend to be provided with medications as a first-line treatment. That ultimately, it's often difficult for them to access the evidence-based treatments that in a timely manner. And those who do actually access it tend to get it at a lower intensity than recommended. One of the important questions we tried to answer as part of the study was, does the quality of the experience of receiving the diagnosis of BPD subsequently affect how people engage with their treatment? Some of the factors we were considering within the study were things such as medication use, the presence of comorbid diagnoses, their experience at the time of the diagnosis, and whether or not this had an impact on the time to diagnosis and treatment. Predominantly, we got a lot of quantitative data, but there was some qualitative data that we also were able to obtain through some open-ended responses within the online survey that we distributed to various networks to try and capture a broad picture of people with a lived experience of BPD in Australia. In particular, we tried to focus in on 2 timeframes. So looking at the onset of BPD-related symptoms to the time of BPD diagnosis, which we termed time to diagnosis, and then subsequently the time from receiving the diagnosis to actually engaging in BPD-specific treatment. 170 eligible participants commenced the study survey, and the completion rate was about 76%, and we did notice gradual attrition as the survey progressed. The age of participants ranged from 18 to 62, and the survey population was predominantly female and predominantly in the younger adult age bracket. There were some older participants as well as a minority of male and non-binary participants as well. I'll now take you through some of the results that came out of the study. As you can see, this particular table summarizes some of the important time points the study wanted to consider in terms of the consumer's journey through their mental health recovery. The onset of BPD-related symptoms have on average occurred at 14.1 years of age, and it was until an average age of 18.7 years that consumers were first able to access mental health services. Was then a significant difference to the average age where they were initially diagnosed with borderline personality disorder, which was 28.7 years. And furthermore, of those who were able to access BPD specific psychotherapies, their average age of accessing this was 31.9 years of age. This particular table was one of the key findings that came out of the study. One of the factors we were looking at was the experience of receiving a diagnosis of BPD. And when we look at what a consumer perceives as helpful communication at the time of diagnosis, these particular consumers went on to be able to access treatments in a reduced time frame of 0.91 years as compared to those who experienced their communication as unhelpful at the time of diagnosis, where it took them 3.17 years to be able to access treatment for their BPD. Similarly, when we look at prognosis that was conveyed at the time of diagnosis, those who received an optimistic sense of their recovery were able to access, on average, their treatment within 0.91 years, whereas those who receive pessimistic sense of recovery, it took them 3.28 years to be able to receive their treatment. In this table, we looked at the open-ended results and responses from what people felt was helpful communication and what they felt was unhelpful communication that they experienced at the time of diagnosis. And as you can see from the themes, it really comes down to the type of support or resources they were provided at the time of diagnosis, the quality of the information they received, how clear it was, whether or not it was personalized to the consumer, and how thorough the information they were provided was, as well as the attitude of the clinician providing the diagnosis, where a non-judgmental, reassuring and validating approach seemed to be viewed as helpful. Conversely, a lot of the unhelpful communication seemed to focus around lack of information, lack of resources or support, and a strong sense of pessimism, judgmental, or even dismissiveness of their consumers' experiences. Another important finding was that actually the prior diagnosis of any comorbid psychiatric disorder or prescribing of psychotropic medications seemed to increase the time to diagnosis. And as mentioned, the quality of communication at the time of the diagnosis was also positively associated with timely access to treatment. Some of the factors that seem to reduce time to treatment and allow people to receive timely treatment included receiving psychoeducation at the time of diagnosis, any opportunities for family care involvement, and referral to either a specialist personality disorder service or referrals to private psychiatrists. Interestingly, a factor that seemed to increase time to receiving treatment was a referral to other public mental health services. That brings me to the end of the presentation. Look, I appreciate your attention. Again, apologies that I couldn't be there in person, but thank you for providing me the opportunity to share some of the research that I was a part of.
Thank you so much, Ian. Really, really good work, and provides a lot of very, very critical insights to anybody who works with people who dealing with BPD, and just the way in which you can influence the way in which they regard their own prognosis for recovery. I'd like to welcome now another student. We have a lot of fabulous high degree research students. This is Ms. Natalie James, and Nat, as she likes to be known, she is a final year student of the Doctor of Clinical Psychology at Deakin University, and we've had so much fun working with her over the last few years. Her important project is looking at the intersection between borderline personality disorder and substance use disorder. Of course, they often co-occur, and we presume that having them at the same time does have an impact on how people present, but also in the way that they're able to engage with treatment and persist with it to the point where they actually go into remission. So her project is all about that, exploring the relationship between co-occurring borderline personality disorder and substance use disorder. And thanks, Nat, your project is really teaching us a lot.
Hi, my name's Nat, and I'm a Doctor of Clinical Psychology candidate at Deakin University. Today I'll be presenting the results from one of the studies of my doctoral thesis, which is entitled Exploring the Relationship Between Co-occurring Borderline Personality Disorder and Substance Use Disorder. You can see my supervisors' names and project team member names are listed there on the slide, and I'd also like to thank Spectrum and Turning Point for their collaboration on this research project. Before I begin my presentation, I'd like to start by acknowledging the traditional custodians of the land on which I present from today, the Wurundjeri people of the Kulin Nation. I'd also like to pay my respects to elders past, present and emerging, and I acknowledge that sovereignty was never ceded. So just to give you a quick overview of my overall thesis, as I said, I'm exploring the complex relationship between co-occurring BPD and substance use disorder. Specifically, I'm trying to understand what the differences are between single versus co-occurring diagnoses, and this is in relation to demographic factors, clinical features, symptom severity, risk profiles, psychosocial functioning, and factors that contribute to difficulties with treatment engagement and completion. I'm also looking at client and clinician experiences of these diagnoses and treatment, and trying to understand what can be done to improve service access and the services that are provided to this co-occurring group. So today I'll just be presenting the results of my first study, which is a file audit study, specifically the first research question. So we conducted a file audit study looking at clinical files of clients from Spectrum and Turning Point to understand some of these differences. So the aims of this study were to examine the differences between these three client groups, so BPD, SUD, and co-occurring BPD and SUD, from two specialist treatment services, so Spectrum and Turning Point, on the following key outcome variables. So demographic factors, psychosocial features, clinical features, symptom severity, functional impairment, risk profiles, and patterns of treatment engagement and completion. Our second aim for this study was to examine the differences between the three groups in relation to dysregulated behaviours and how these, along with other clinical features, might affect treatment engagement and completion. As I said today, I'll just be presenting the results from the first research question, which is what are the differences between treatment-seeking groups with BPD, SUD, and co-occurring BPD and SUD on demographic factors. So this includes things such as age, sex, country of birth, living arrangements, employment, school and education completion, civic and community engagement, and core relationships and family history. We hypothesised that the sample of people with co-occurring BPD and SUD, as compared to people with SUD or BPD alone, would have a more severe clinical profile, greater symptom severity, a higher risk profile, greater psychosocial and functional impairment, more frequent treatment disengagement, and would engage in more frequent or severe dysregulated behaviours. This might not be surprising to the clinicians listening today. However, what we know is that this is sort of anecdotally known, but there isn't really much research to support this at this point in time, which is why we're conducting this study. To give you a bit of information on the research design and methodology, we've utilised a between groups design to compare the differences between the client files of these 3 diagnostic groups. A power analysis identified that a sample of 90 participants would be needed in order to obtain meaningful differences between the groups. So initially the plan was to split this with 30 participants per group. However, we ended up having 32 participants in the co-occurring group, 28 in the BPD only group, and 30 in the substance use disorder group. And this was because we found, after commencing the auditing process, that 2 of the participants that had been included in the BPD group had historical substance use disorder, so they were moved to the co-occurring group. In terms of the file audit tool itself, this consisted of about 150 variables and was developed based on existing literature to capture some of those key variables of interest that are listed there on the slide and that I've previously mentioned. So this is quite an extensive process with input from clinicians and yeah, as informed by the existing literature. Data was collected from clinical files from 2 specialist Eastern Health Treatment Services, Spectrum and Turning Point, and audits were conducted retrospectively. In terms of the analysis, we utilised a linear regression model to compare the differences between these 3 groups. The inclusion criteria for the study were that participants needed to have a current diagnosis of BPD, SUD, or co-occurring BPD and SUD. This could include a lifetime diagnosis. It didn't need to be concurrent. So it was okay, for example, if they had BPD symptoms now and maybe had used substances or had a substance use disorder earlier in life but weren't currently using substances, or that was in remission. And these were based on meeting the diagnostic criteria as per the DSM-5 or the ICD-11. In terms of the period of needing to have attended the service, people or clients needed to have engaged after 2014 and discharged prior to December 2020. Our exclusion criteria were that any files with incomplete record keeping, which resulted in excessive missing data, were excluded. Anyone who'd only attended for an assessment session and not engaged in treatment, and anyone that was known to myself as the lead author. In terms of our sample characteristics, the mean age for our sample was 35 with a range of 15 to 64. We had 77% of the sample were female with 23% male, although we had 2 participants who were gender diverse and identified with a different sex to what they were assigned at birth. We had 3 participants who identified as Indigenous Australians. All 90 of our participants spoke English, and we had 7 participants who were born in a country other than Australia. We've also noted there that we had 3 participants who were currently completing high school, and this was because some of the variables that we're looking at were relevant to later developmental periods, such as adulthood, and also things like school completion, relationship status, whether they had dependent children, obviously were less likely if they were young and still completing high school. We also had most of our participants actually living in stable housing, with 7 participants living in unstable housing, 50 participants were using substances currently, and we also had 12 participants who had a historical substance use disorder. Of the 62 participants who had used substances, 11% were engaged in alcohol use only, 30% were engaged in single drug use, and 59% were engaged in polysubstance use. Interestingly, the co-occurring group had a high probability of engaging in polysubstance use. And of the substances that were used the most, alcohol, cannabis, and tobacco were noted to be commonly used. In terms of traumatic experiences, 91% of participants had experienced a traumatic event in their lifetime, with 98% of these participants having experienced multiple traumatic events. So not surprising, but an interesting finding. In terms of the preliminary findings to answer research question 1, we found that there was strong evidence of differences between the diagnostic groups on the following variables. So age categorised by developmental period, sex, employment status, whether someone was receiving a pension or not, study status, completion of a higher education or a university degree, relationship status at intake, dependent children at intake, and whether they had support from a case manager. We also have noted there that there were a couple of variables where there wasn't any evidence of a relationship, but I won't go into these given the short length of time we have today. There are also a number of variables that were too low frequency to determine if there were any differences, so they would require further research to be conducted with a larger sample. There were also 2 variables that had some evidence of a relationship, but due to low power, this was insufficient to draw any conclusions. So that was parental or familial substance use disorder history or mental illness history. Now, this might look a little bit overwhelming and confusing, but I'll try and break it down and make it as simple as possible. But what you can see there on the screen is the proportions of people who met the variable criteria on the left for each of the diagnostic groups. So I'm just going to spend the last minute sharing a couple of the interesting findings from the first research question. So as you can see there, the BPD group was predominantly younger people, or people in the 15 to 25 age category, as opposed to the SUD group, which was 63% people in the 40 to 65 age category. So quite a difference in age there. We also noted that there was a higher probability of being female in the BPD and co-occurring group, and the SUD group was split 50-50 in terms of sex. There were also a lower proportion of people who were unemployed in the SUD group, and also a lower proportion of people receiving a pension. So we're planning on controlling for age and sex, given that you can see that quite a lot of these differences appear to be explained by that. So it'll be interesting to see if there's still any results after we do so. Similarly, study status had a high proportion of people in the BPD group, which makes sense given that they are quite young. A high proportion of people in the SUD group had completed a university degree and were in a relationship at intake, and also had dependent children. So again, maybe explained by age, but we're planning to control for that to see if that explains the difference or if it is actually a difference between the groups. And finally, people who were in the SUD group had a 10% 10% of them, had a case manager at intake, which I guess speaks to the fact that the mental health system and substance use treatment in Australia is quite separated. So as I said, we're planning on controlling for the covariates of age, sex, and whether someone was in treatment during COVID-19 to see if that may explain some of these differences. We also have to complete the analyses for research questions 2, 3, and 4. And we'd also like to note that future directions for research is that I guess we should also be looking at a broader, more representative community sample of people who aren't accessing specialist treatment services as well, given that we were utilising a treatment-seeking sample. Thank you for your time today, and please feel free to type any questions in the chat box.
Thanks very much, Nat. Great work. It's a lot to write up, but it's going to be fabulous when it's all put together. So congratulations on a huge body of work in our field. I just want to remind everybody that although these talks are pre-recorded, there is a live Q&A. So if you have questions or comments as these presentations are playing, please type them into the chat, because the presenters are standing by and they can respond to your comments. Our next speaker, number 7 of 8, is my wonderful colleague, Dr. Pavana Haidari, who likes to be known as Parry. She has been with Spectrum for 3 years now. She received her PhD from Monash University, and she now works in several major projects at Spectrum, one of which is a very important series of studies looking at how people received support, whether they received support and how they did during the early lockdown, before we kind of had our systems all adjust to the frequency of lockdowns we had, particularly here in Melbourne. So her topic today is mental health support and telehealth use in Australians living with BPD during the onset of the COVID-19 pandemic, a national study. Thanks, Parry.
Good afternoon, everyone. My name is Parry. I'm one of the research officers at Spectrum, and today I'm going to talk about one of the research studies that we have done at Spectrum, which is an investigation of mental health support and telehealth use in Australians living with BPD during the onset of the COVID-19 pandemic. As we all know, following the imposition of social restrictions across Australia in March 2020 to limit the spread of COVID-19, there was a rapid national shift to deliver mental health services using telehealth. And we see nowadays that telehealth came to stay. In this study, we conducted an online national survey of people living with BPD to investigate their mental health service use and telehealth experience during the first year of the pandemic. Why BPD? BPD is a severe and complex mental health disorder, and people with BPD may experience intense emotions, have trouble with relationships, or intentionally harm themselves as a way of coping. That's why learning from their experiences will be beneficial when planning future telehealth-based interventions. We conducted an online national survey using multiple choice questions as well as open-ended questions to be able to do a convergent parallel mixed method study. The survey was live during July and August of 2020 to capture the experiences following the first national lockdown. People residing in Australia who self-identified with a diagnosis of BPD were invited to participate. And this study received approval from the Eastern Health Ethics Committee. In 10 minutes time of the presentation, I cannot cover all of the findings of the survey, so I only report some parts of the findings. In total, 226 surveys were submitted, from which 169 surveys were included in the analysis. Survey responses were excluded if more than half of the questions hadn't been answered. As you can see, the majority of participants were female, resided in the most populous states of Victoria or New South Wales, and they aged between 28 and 47 years. Depression and anxiety were the most common comorbid mental health disorders. 23% of the participants lived alone, and in terms of employment, 28% of participants reported being unemployed prior to the pandemic. This table shows the availability of mental health services during the restrictions. Last column shows that overall mental health service use was low in these participants, particularly use of public mental health services. The most common mental health service that participants were accessing prior to the pandemic was in-person treatments from a private psychologist. Participants who were accessing mental health services prior to the pandemic stated that the majority of these mental health services continued to provide care in person or via telehealth during lockdown, with only a few ceasing to offer any services. More than half of the participants stated that they didn't receive information about access to alternative supports and services during the restrictions. They noted that receiving information about helpful resources, if they become distressed, would be very helpful. The majority of participants access telehealth services to obtain support for some aspects of their mental health during the restrictions. The most commonly service they received via telehealth was consulting a psychologist or obtaining prescriptions. And the majority of participants accessed, you can see that on the pie graph, that the majority of the participants, like more than 70%, accessed telehealth services to obtain support for some aspects of their mental health services. Most participants used a mix of phone and video conferencing, with 31% using only phone and 17% using only video conferencing. And there were no statistically significant differences between the demographic characteristics of participants, such as age, location, or gender, and their preference for telehealth compared with in-person services. And no matter which tool they use for telehealth, more than half of the participants expressed a desire to retain the option of telehealth services for future mental health needs. Keeping in mind that despite this, participants consistently affirmed that in-person treatment was more beneficial for helping them with their mental health difficulties. When participants were asked how helpful has accessing services via telehealth been for them, about 91% of participants found telehealth benefited their mental health, and only 8.8% stated that it was not at all helpful. Thematic analysis of the responses to the open-ended questions identified 5 main themes: communication challenges, technology challenges, privacy concerns, benefits of telehealth, and personal preferences. In this and following slides, I go through these themes briefly. For example, in terms of communication challenges, they simply said that they missed in-person human communication and they felt isolated. Or sometimes they felt like that the body language is missed via telehealth. Also, they mentioned that it was difficult for them to stay focused while using telehealth. Attention span and screen fatigue are widely experienced, making it more difficult to maintain concentration. One simple solution can be to increase the frequency of shorter duration telehealth sessions. In terms of technology challenges, you might already know these challenges like poor quality of internet connection, or poor access to poor quality of equipment, or for example, health provider was not flexible with the video conferencing platform, or the health provider only offered phone. Additional resourcing of mental health services by health departments would enable the provision of reliable equipment and improve the coverage and quality of internet access. Supporting telehealth should be a priority as it greatly improves equity of access to treatment services for people living in regional and remote locations. Some privacy concerns were raised by participants. For example, they had concern that other people in the clinician's home can hear them, or vice versa, someone at their home can hear them. One recommendation for all of the concerns that raised is that when mental health clinicians engage with clients for treatment via telehealth, they consider applying a checklist that asks about the challenges and concerns their clients might have. This may assist in deciding whether and when telehealth is suitable for individual clients, particularly if they have BPD-associated difficulties. Benefits of telehealth were also acknowledged by participants, they save a travel, they were flexible about the time, or they are less stressed to leave the home, or simply they are more comfortable in a familiar setting of their home. And the last but not least, they just said that some people had preferences. They simply like telehealth better than in-person, or vice versa. They prefer in-person services. These were the summary of the findings. Full results are under review in Digital Health Journal at the moment, and hopefully it is accepted for publication. Thank you for your attention.
Thank you, Perry, for a great presentation of this really important work. Telehealth has really taken on a life of its own now with our heavy reliance on it, even to the point of conducting virtual conferences. It's just made everything so much more possible. Our final speaker of our 8 in this rapid fire session is my boss, actually. It's Associate Professor Sathya Rao. Sathya is I don't know how to describe it. I have such fun working with him. He's got a wonderful research mind. He's a psychiatrist. He's the executive clinical director of Spectrum. He's an amazing teacher of future psychiatrists. He runs, a lot of research as well. He's published, he's written book chapters, he's invited speaker. He's amazing. He's been recognised recently by his peers with the Meritorious Award in the Victorian branch of the Royal Australian New Zealand College of Psychiatry. And this year, amazingly, he received the award of the Medal of the Order of Australia in the Queen's birthday celebration. So very, very accomplished, extremely passionate, big on advocacy. He's the Vice President of the Australian BPD Foundation. So if there's something to be done with personality disorder in Australia, Sathya is going to be involved, if not leading it. So I will pass the baton to him now, and we'll enjoy his insights. Thank you.
Hi, I'm presenting on treatment of complexity in borderline personality disorder, a Spectrum experience. Spectrum is a statewide public mental service specializing in the treatment of people with personality disorders and complex trauma. The typical profile of patients accessing Spectrum treatments are those who have severe and complex personality disorders with significant trauma histories and co-occurring mental health conditions with high suicide risk, and usually they have not had benefits by accessing treatments elsewhere. Our treatments at Spectrum are typically for 12 to 18 months, and they are BPD specific treatments, most commonly dialectical behavior therapy, mentalization based treatment, or acceptance and commitment therapy. The objective of today's presentation is to present the Spectrum evaluation data related to some of the mental health disorders that co-occur with borderline personality disorder, such as depression, substance use disorders, eating disorders, and other personality disorders. I will not go into the methodology of research. In this paper, my colleague, Dr. Agarit, will be presenting the methodology in detail later on. We know that co-occurrence is very common in borderline personality disorder when it comes to other mental health conditions and other personality disorders. So as someone said, BPD is the king of comorbid kingdom. And similar data is seen with the Spectrum population as well. We looked at the data for emergency department presentations of people with a diagnosis of personality disorder. And it again shows that when we compare for depression, people with borderline personality disorder who access emergency departments seem to have significant co-occurring mental health conditions. When we look at the coronial data for suicide in Victoria, we again find that people with borderline personality disorder who have co-occurring substance use disorders and other psychiatric disorders such as mood disorder, schizophrenia, behavioral syndromes, etc., tend to have a higher risk for death by suicide. We looked at the data for depression and borderline personality disorder. Our data shows that when compared to baseline, with treatment at discharge, that is about 12 to 18 months later, as well as at follow-up 12 months later, there is significant reduction in depressive symptoms for people who are treated at Spectrum with psychological treatments. What's more important is that these patients typically have a reduced need for medications, including antidepressants, at discharge and at follow-up. What it shows is that if we treat people with borderline personality disorder who are co-occurring depressions with psychological treatments, they get well without medications and do not need medications even in the long term. We looked at our data again for a slightly larger patient population, nearly 114 patients. Again, the similar data is shown comparing baseline and at 18 months at the time of follow-up, significant reduction in depressive symptoms. When we look at co-occurring substance use disorders, we compared the data for people who completed the treatment and people who did not complete the treatment. For non-completers, they had increased, they were smoking more, they're smoking tobacco more, smoking cannabis more, and were using amphetamines. The people who completed the treatment tended to have a more sedative use. When we look at the baseline and the discharge data, so the pre and post treatments, there is significant reduction in substance use disorders at discharge, except for tobacco and cannabis. So what it shows is that comparing the two, the previous slide and this slide, people who use cannabis and tobacco and amphetamines were seen more often in the non-completers group. But if they stick to the treatment, when they complete the treatment, again, for tobacco and cannabis, there is no significant reduction. When we looked at the eating disorder symptoms that co-occur with borderline personality disorder, we see a significant reduction over 18 months on all the subscales. When you look at the other co-occurring personality disorders, that is borderline personality disorder plus other personality disorders, we see a significant reduction in avoidant personality disorder symptoms, depressive personality disorder symptoms, as well as obsessive compulsive personality disorder symptoms. One could argue that there is a significant overlap between borderline personality disorder and depressive and avoidant personality disorders, and probably that is why the change happens. But there is also a trend towards reduction in other personality disorder symptoms as well. When you look at a slightly larger patient population, when we look at the data for 114 patients, again, a similar story is seen with a reduction in other personality disorder symptoms when we treat people for only borderline personality disorder. So overall, the findings are that other mental health conditions and personality disorder symptoms commonly co-occur with borderline personality disorder, and treatment of borderline personality disorder with psychological treatments result in beneficial effects for co-occurring mental health conditions such as depression, eating disorders, and substance use, even for the most severe and complex personality disorder cohorts. Obsessive compulsive personality disorder, avoidant and depressive personality disorder symptoms improve when we treat borderline personality disorder with psychological treatments. In conclusion, we need to prioritize treatment of borderline personality disorder with psychological treatments, even when they co-occur with other mental health conditions. And for the most severely unwell and complex personality disorder patients, even for them, prioritizing borderline personality disorder treatment is helpful for treating co-occurring mental health conditions such as substance use, depression, and eating disorders. However, it would be interesting to further explore if borderline personality disorder psychological treatments would be helpful in treatment of depression, eating disorders, and substance use disorders if they did not co-occur with borderline personality disorder. Thank you.
Thank you so much, Satya. I hope you have enjoyed this series of presentations, the variety and the individual styles that have come through, hopefully that have kept you really engaged with the program.